Good evening all and welcome to the Carolam Cymru revision sessions. This session will focus on A2 psychology and will be delivered by Mrs Bellis from Allen School in Flintshire. The recording of this session will be uploaded onto the e-sgol website under the Carolam Cymru tab, and the Q&A section is available within this live event if you want to ask any questions, and we'll endeavour to answer them during the session. Great, thank you so much. Over to you, Miss Bellis.
Thank you. Hi everyone, welcome back to the A2 psychology sessions. In this session, we are going to start looking at the methods of modifying schizophrenia. So we've already looked at quite a lot of our explanations, but now we are moving on to how we actually treat schizophrenia. And there's two different methods to look at here. There is the use of cognitive behavioural therapy and also the use of drug therapy. So we are going to have a bit of a chat about the content, and also I'm going to give you some examples that you can bring into an exam answer as well. Okay, so modifying schizophrenia. Modify is just change or treat. So in the exam, you will be, well, maybe asked to modify and look at the methods of modifying it. Now, as of the 2023 exam series, methods of modifying schizophrenia and its evaluation is on the advanced information. But I just want to make that clear that that is the summer exam series of 2023. So if you're watching the session beyond that, then it may be different. But for those of you sitting your exam this year, modifying schizophrenia and its evaluations is named on that advanced information. So it is likely that it will come up this year. Now, there is a lot to this, and I've got quite a lot to cover in this session, because they do go into lots of detail about the two different methods. So even though lots of it is covered in AS psychology, and lots of this you will remember, there is a little bit more sophistication that you would expect to see in year 13 here. So there's lots of different ways to treat or modify schizophrenia. There has been lots of different biological explanations, so drugs, which we're going to look at today, ECT and psychosurgery, which is essentially literally surgery on the brain. Or there are less invasive techniques such as cognitive behavioural therapy. And I'm going to talk you through both drugs and CBT today. And we're also going to discuss how actually they are best used together as a method of modifying schiz, because one alleviates the symptoms, but one allows you to restructure your actual thoughts around the symptoms. So they are best served as a pair. But we're going to speak about them separately, and then I'll also mention about how they are normally included together. So first thing is, what is an antipsychotic? Now, an antipsychotic is something that is in the drug therapy for our year 12 biological approach, and it is something that you also need to be familiar with here, because the type of drug to treat schizophrenia is an antipsychotic. Psychotic and psychosis is that idea that you are losing touch with reality and what is real in your environment. An antipsychotic tries to bring you back down to earth slightly. We also know from the biological approach that the cause of schizophrenia is having too much of the neurotransmitter dopamine. So essentially, we want to dampen down the amount of dopamine that's in somebody's brain, and an antipsychotic drug can do that. So at the start of any essay to do with drugs, whether this is AS psychology and we're talking about drug therapy, or whether we are looking at drugs as a method of modifying, you need to show the examiner that you understand how drugs move around the brain and can possibly change aspects of neurological function. So it says here, neurotransmitters are chemical messengers and they transmit signals from a neuron to a target cell across a synapse. Now, I'm hoping that that isn't new information for any of you, and this is something that should have been covered in AS as well. And we know that dopamine is the neurotransmitter that we really want to act on when we're treating schizophrenia. So messages are sent via synaptic vesicles, and your neurotransmitters are packed inside of synaptic vesicles. And what happens is they are on the presynaptic side of the synapse. And then when an electrical impulse called an action potential reaches a threshold, vesicles are released, which means that your neurotransmitters in your brain are free to move around. They are released and they diffuse across the synaptic cleft. Synaptic cleft is a really, really tiny gap between two neurons. They diffuse across the gap and then they attach themselves, they bind to the receptor sites on the postsynaptic neuron. They are then taken by the presynaptic neuron or diffuse away. And I've got a photo here of that happening. So the blue circles you can see, and they are labelled, they are your synaptic vesicles, so they will hold your neurotransmitters and they will travel right to the end of your presynaptic neuron, which is here, and then they diffuse across this gap called the synaptic cleft, and they bind to the receptors here, and then they carry on down the brain and around the brain to signal an emotion. So that is, first of all, how neurotransmitters work, and you need to be able to explain that to an examiner so that they can just show, you can show your understanding of how drugs work. Now, something to be aware of here is our dopaminergic pathway. Like I said previously, dopamine is the main neurotransmitter associated with schizophrenia. And we have got a dopaminergic pathway, a pathway that dopamine travels on and around. It's called our pleasure reward pathway. Now, it's all centered around our limbic system, which is in the very, very center of our brain. You can't really see the limbic system here, but this is your corpus callosum, which is a piece of brain matter that attaches both hemispheres together. So we're right in the middle of the brain here. And then underneath here, this sort of dark orange space is your lateral ventricle. And a ventricle is a gap in the brain that creates and transports cerebral spinal fluid. So right in the depths, in the middle there, is your limbic system. And that structure is sort of where dopamine lives. And what happens is dopamine is taken from something called your ventral tegmental area, which is in the green here. And it either travels forwards or backwards, depending on which symptoms you are experiencing. So it goes from either the nucleus accumbens, it goes from the ventral tegmental area to the nucleus accumbens, or it can go from the ventral tegmental area to the frontal cortex. But there are specific pathways in the brain that the dopamine travels on, like a bike-only lane on a road or a bus lane. Dopamine has its own lane in the brain. So that is something just to be aware of as I'm going through the rest of this explanation. So how do antipsychotic medicines work? They work by either increasing or reducing the effects of a natural chemical, so neurotransmitters, in the brain, and that includes things like dopamine, serotonin, noradrenaline, or I always get this wrong every time I say it, but I think it's acetylcholine or acetylcholine. And they are all neurotransmitters that are to do with our mood, and they affect how we feel and how we behave. The neurotransmitters regulate numerous aspects of behaviour. So it's our mood and our emotions, like I said previously, our control of sleeping, how awake we feel, and our control of feeding as well, so our appetite. They can be classified by their chemical structure, but they can also be distinguished by their pharmacology, which is the action at different transmitter receptors, and by their clinical properties. This is how they work. There's lots of different types, and they help us regulate our emotions and our behaviour. So there are two different types of antipsychotic drugs that you need to know about. The first type is a typical antipsychotic, or they're also known as conventional antipsychotics. They are slightly older, they are slightly more traditional. And they were first developed in the 1950s, and they very simply decrease the level of dopamine in the brain. So we know people with schizophrenia have too much dopamine, we want to reduce it. Typical antipsychotics will do that. Okay, so there's two different types of typical antipsychotics that are licensed for use in the UK. You have got chlorpromazine and fluphenazine. Now, difficult words to remember, but really, really crucial that you get them into your answer, because they show a real depth of knowledge and understanding of this methods of modifying. So I know it's frustrating that you have to remember those names, but they are super important. And chlorpromazine and fluphenazine are neuroleptics, and neuroleptics essentially means that they seize the neuron. So those neurons that have got dopamine in are seized, they are stopped, which therefore dopamine levels are decreased, which is what we want. But the problem with this is that they have quite nasty side effects, especially the older sort of drugs. So we know that there is a link between dopamine and Parkinson's disease because of the use of dopamine in the past. So that means that sometimes the symptoms that you get from taking something that reduces dopamine in the brain is that of Parkinson's disease. It doesn't mean you get a diagnosis of Parkinson's disease. You haven't actually got it, but it just means that you get Parkinson's-like symptoms. So Parkinson's is a degenerative disease of the brain and the limbic system, and it affects your memory, but it also affects movement and your muscles. So sometimes if you lower the amount of dopamine in the brain, you end up seeing some quite nasty side effects. So muscle tremors, increased appetite, tooth decay, and it could even lead to diabetes. So it's very much you have to outweigh the pros and cons. You know, yes, there is going to be quite bad side effects with this, but does that mean that your schizophrenia symptoms are reduced, and would that be better for the person? There's lots to think about when administering drugs as a treatment. Then we've got the newer antipsychotics, which are your unconventional, and they are known as the atypical antipsychotics. Now, they were first developed in the 1970s, and a new generation of atypical antipsychotics appeared in the 1990s. So not that long ago, really. And atypical antipsychotics are less likely than typical ones to cause movement disorders. So moving away from that really bad Parkinson's-like side effect. So this was kind of seen as better, I suppose. But when in higher doses, they still cause movement disorders. And I suppose it's like anything, really. If you take a lot of something, then obviously your symptoms are going to be worse, or the side effects of that drug are going to be worse. So on the whole, they cause less movement disorders, but taken in higher doses would. And you can see this very, very, very big list. And the following atypical antipsychotics are licensed for use in the UK. Now, I'm not going to butcher all of the pronunciation of these words, but one that would be good for you to bring into an essay is clozapine, and I've put that one in red. That is a type of atypical antipsychotic. Okay, so this is an excerpt of the notes and the booklet that I use when I am teaching my Year 13 psychology students. They need to know about typical and atypical drugs, and they need to know the specifics about clozapine and fluphenazine, which is what I've got here. So Clozapine is your atypical, and it affects the neurotransmitter dopamine. Perfect, that's what we want. And it works by blocking the receptors in the brain that dopamine acts on. It prevents the excessive activity of dopamine and helps to control psychotic illness. So unlike fluphenazine, which is that idea of a neuroleptic, this one tries to block the receptors so that it cannot even receive dopamine in the brain. Clozapine is restricted to treating schizophrenia in people who have not responded to or are intolerant of other treatments. So people that have maybe tried other things, maybe they've tried a little bit of CBT and things aren't working. So clozapine is another option. Okay, so it's quite strong, and obviously it can have quite bad side effects. We have to be quite cautious of when we administer it. It can cause rare but quite serious side effects. So not all the time, but we really have to think, is this going to be beneficial, and is this going to be better for the individual that has the schizophrenia? And then at the bottom, we've got that link with Parkinson's disease again. So it's also used for treating psychotic illnesses in people with Parkinson's where other treatment has not worked. So that is your example for atypical drugs. And again, I always go on about how important bringing examples are into your answer, and this is, again, something that absolutely does need to be in an answer on methods of modifying. The next example, like I said, is fluphenazine, and that is a typical antipsychotic. It is used for treatment of psychosis, but also acute manic phases of bipolar disorder. So it has multi-purpose, really. And I think the second and third bullet points here are really, really interesting, because it's actually not taken as an oral tablet. It is a long-lasting injection given every 1 to 2 weeks for people with schizophrenia who have poor compliance with medication. So people that either forget or don't want to take medication every day, because that's what you would have to do if you were taking clozapine. Instead, they would get an injection. This has also helped people that are often relapsing, maybe for other reasons, but one of the reasons could be not sticking to a routine with taking medication. So this, although yes, there are issues with getting somebody with schizophrenia to take an injection, especially if they are dealing with delusions or hallucinations and delusions of grandiosity or persecution, that people are after them. Sometimes if they are in a manic episode, then it is obviously not a great idea to administer an injection, because they are going to be quite severely paranoid about what is being injected into them. But to reduce that that long-lasting issue, having an injection is preferred for lots of people that have schizophrenia. Now, again, like anything, it's going to have side effects because it is a drug, and all drugs do. And its side effect profile is similar to something called haloperidol. And that is, again, similar, really, dopamine blocking effects, which give rise to various different things, again, linked to Parkinson's. So akathisia, which is to do with your heart, Parkinson's disease, and tremors again. So fluphenazine is your typical antipsychotic, and then you've got clozapine, which is your atypical antipsychotic. Now, before I go on to cognitive behavioural therapy and speak a little bit about that, one thing that's common, like I keep saying, is side effects. It is a massive problem. And although it kind of feels a little bit like it's an evaluation point, it is still something that you need to talk about and include in an exam question. So there are side effects, and the most common ones, like I've said, are things that resemble Parkinson's disease. So a dry mouth, blurred vision, constipation, feelings of dizziness or lightheadedness, and significant weight gain. But rarely, antipsychotics may cause more serious side effects, such as diabetes or metabolic syndrome, neuroleptic malignant syndrome, which is a fever, feeling quite breathless, sweaty, muscle stiffness, going in and out of consciousness, and having an irregular heartbeat. And those things are quite scary, aren't they? You know, even if you just cannot catch your breath a little bit, it can be quite scary. And therefore, I can kind of see why maybe there is a lack of compliance, because the side effects are quite harsh, aren't they? Antipsychotics can also increase the risk of having a stroke in elderly people that have dementia. So it really is a pros and cons, isn't it, here? And again, sometimes it's people that have very severe schizophrenia, or schizophrenia that has gone through lots of other methods of modifying and maybe hasn't worked. This, because it is so strong and because of the side effects, it may be people's last port of call. Okay, so that is a little overview then of that drug and use of antipsychotics method of modifying. The most important things you need to include here, like I said, are synaptic transmission, how the drugs work in the brain, the different types of drugs, and then the examples that I've given you, which are here, clozapine and fluphenazine, and bringing in side effects as well. Now, some top tips on the screen about how I would go about revising this, creating that keyword glossary, so having things like clozapine, chlorpromazine, fluphenazine, things like tremor, Parkinson's disease. They're all key terms that are really going to make sure you get that terminology in your answer, which gets you up that top mark band. So creating a keyword glossary and making sure that you understand those words. Researchers' names, again, there isn't really many with methods of modifying. There is for CBT, which I will go on to speak with you now. And then write everything you know. What do you already know about synaptic transmission? Can you draw the pre and post synaptic neuron and explain it to somebody? And then go in to your notes and have a look at what you've missed, review it. And the last thing that I would do, absolutely, especially for something that's quite tricky like this, is write an example essay. Write an essay, use your notes, make sure it's perfect, revise it, write it out again without your notes, and keep going over it so that you get better timing, okay? Because timing, you know, you've got 2.5 hours in this exam and you've got a lot to get in that time. So it's making sure that you are practicing that timing, but also making sure that you've got absolutely everything you need in that essay. So if you're unsure on where to start with revision for this, because it can be quite overwhelming, I would start with a keyword glossary and then work your way through those bullet points. Okie dokie. Moving on then, we are going to have a look at our other methods of modifying SCIT, which is cognitive behavioural therapy, CBT. Now, this is in the Year 12 specification, slightly different because you need to know about a specific person in Year 13, whereas in Year 12 it was very general. Year 13 is very much about one person and the techniques that they have tried out, and it's more specific for schizophrenia and not just mental illnesses in general. So the cognitive approach is all to do with you logically thinking about your thoughts, how you process things, your memory, your perception, your senses and how you see them and what you get into your memory from your outside world. And when it comes to considering the cognitive approach and schizophrenia, they don't really marry up very well, because the treatment relies on logic. It's you thinking about your thoughts and feelings and saying whether you believe they're going to come true, or saying whether you can provide evidence for or against them. And we know that people with schizophrenia lose touch with reality. So if you don't know what's real and what's not, how are you going to have logic over your thoughts? So for a long time, it's been sort of not disregarded, but not really favoured as a treatment, and people have really stuck with drug therapy. But now, and especially paired with drug therapy, cognitive behavioural therapy has been really, really helpful, because not only does it provide more of a deeper understanding of why you feel that way, it also sort of puts the onus on the patient and actually gives them a little bit of empowerment to be independent in treating their own disorder, which is really nice, and something that is the opposite of drug therapy. You know, you're very reliant on a tablet that you take each day, whereas CBT puts the onus on you as the individual. So more recent studies have shown actually that psychotic disorders are merely distortions of a person's perception, and so they could be considered as having a cognitive cause. And if a person's perception is distorted so that they hear voices, then it should be possible to logically restructure the person's perception to have that more normal view. This treatment may, of course, need to be combined with drug therapy, as it may take a while to be affected. And that bottom bullet point is really, really interesting here, and absolutely something that you can bring into your essays. So what is it? What actually is CBT? It is a form of therapy that focuses on faulty mental processes as a cause of schizophrenia. It believes the person has created faulty thoughts and feelings about something or about themselves. It's effective as it requires the patient to complete homework. And I'm going to show you some examples of the homeworks that are completed later on in my presentation. But it allows to sort of bring them into the real world and take ownership of getting better, rather than taking a tablet or passively allowing the therapist to sort them out. It's all down to them. That's why they do the homeworks. So homework activities is, the first thing is keeping a dysfunctional thought diary. Now you might recognise this because this is also in the AS specification. The dysfunctional thought diary is just a diary, a book, where they record how they feel, what they did, and what they thought about an event. It literally is a diary of your thoughts. Then what happens is they are challenged to think differently about the event and record different possible views of the event. And then, this is the important bit down here, supply evidence for the way that they were thinking. Is it appropriate? And if you are writing down, oh, I think that somebody is following me, or I think that I can see spiders in my house, then, and you write that down, the therapist then discusses it with the client and may say, well, where's the evidence? Is there any evidence that somebody was following you home? Did you see them? Did you hear them? Did you see any spiders? Was there any damage around sort of somebody being in your house? And eventually, not straight away, eventually, they'll realise, oh, actually, that's just part of my schizophrenia. And they're able to separate themselves and the symptoms that they're actually feeling. And that's the very, very start of getting to grips with your own condition. And that's where the empowerment comes from. So the next thing from that is cognitive distortion. Okay, so it makes sense that CBT uses the treatment to deal with thought disorganization. So it connects their patient's feelings and thought patterns that reinforce the illness, and they challenge it. Okay, they get them to think outside of the box. This is is your researcher? So like I said, there aren't very many researchers for methods of modifying. There's lots for the evaluation, but not so much for the actual theory. But Laura Smith et al. 2003 looked at lots of different using CBT, essentially pulled together what she thinks would work best for people that have schizophrenia. And there are many different elements to it. Some of them are on the screen now. So engagement strategies, psychoeducation, behavioural skills training, and relapse prevention. Now, I'm going to talk you through each of those strategies, but before that, here are some of the homeworks that Laura Smith included in her research. So they've got two lists, positive feelings and negative feelings. And sometimes maybe somebody with schizophrenia can't articulate and actually say how they feel. Having them written down in front of them allows them to identify how they feel. So maybe they're asked to circle ones they feel, or just discuss with the therapist. Do you feel embarrassed? Do you feel uneasy? Do you feel worthwhile? Do you feel safe? And they are all sort of starting points for a conversation of understanding your own thoughts and feelings. And then second to that is different calming techniques. Okay, sometimes people with schizophrenia can be quite sort of highly strung and quite on edge. And so keeping them as calm as possible is also a way of then allowing them to talk about their feelings. So ensuring that they are sitting on a comfortable chair or lying down. And it's a little bit of mindfulness, isn't it? Take a breath in for 4 seconds, hold it, and then breathe out for 6 seconds. So the homeworks are a combination of actual tasks for you to do or things that you can write down. And then different types of questionnaires. So what personal benefits to changing yourself do you expect? To what extent do you think your current mode of functioning contributes to the problems you are experiencing? And then we've got a Likert scale. This might be quite difficult for the person with schizophrenia to fill out. But again, with the help of the therapist, this just again allows them to think outside of the box about what they want from the experience of CBT. Then another one, list some ideas you might have for coping with stress and symptoms. This fire drill for coping is very much the idea of taking your own advice. So writing down how you would deal with your stress and your symptoms of schizophrenia, and then maybe coming back to it when you are struggling and reading, oh, actually, it was me that gave me that advice, so I'm going to follow it. Instead of it coming from a professional, it actually puts the onus on them. And then you've got listing vulnerability factors and creating a stress checklist as well. And then lastly, early warning signs worksheet. So one of the quite big things with CBT is understanding your own illness so that you can identify warning signs of when you may relapse or when you may go into an episode of mania. And what can happen then is if you understand when or why or how you're going to relapse, a plan can be put in place. When you start to notice things, think, right, okay, I think you know, I'm feeling quite bad today. It just means that both the person with schizophrenia and the family of those with schizophrenia can work together and know what to do to help the person. Okay, so what I'm going to do now is go through these different components that Laura Smith suggested as CBT for schizophrenia. So first of all, we have got engagement strategies. So patients are able to talk at length about potential worries or any symptoms that are a particular concern. So they, again, just talk to the therapist. And one of the really important things in any sort of therapy, especially if you're dealing with somebody that has schizophrenia, is creating a rapport with the patient. You've got to have a rapport and you've got to build trust, especially when schizophrenia is centered around paranoia and delusions. So really making sure that you have a professional relationship with that client. And if they've had previous bad experiences, then then it can cause more paranoia and it can cause more worry. So it's really important that the therapist and the client have a good relationship. The therapist and the client then discuss the natural coping strategies that they have. And again, it's all about building trust. Then you've got psychoeducation, and this has three main functions. It normalizes this experience of psychotic symptoms, like, oh, you feel worried that somebody may be following you home. Oh, well, that's okay, because lots of people feel like that. If you're walking somewhere and it's quite dark, it is a little bit creepy. So it's just offering alternative explanations and actually saying, no, it's okay to feel like that, or it's okay to feel a little bit scared or a little bit upset, just to normalize it. Okay, make them feel that they aren't abnormal and that they aren't ill. And then the client increases their own understanding of the context. So where do you feel most scared, or where do you think you get the most delusions, or where do you hear the most voices in your head? And again, then it's making sure in which context they are worse or better. And then the therapist can further assess the client's understanding of the symptoms and illness. So this is all part of both the therapist understanding the condition, but also the actual patient as well. Cognitive strategies kind of embeds the homework activities as well. So clients are asked to keep a thought diary where they record how they feel, what they did, and what they thought about a particular event. And then they are again asked for evidence. They challenge themselves. The diary entries are brought to each session, and then they are discussed with that therapist again. Also within cognitive strategies, you have behavioural experiments. So these are created to challenge their beliefs, such as, I have no control over the voices I hear. Instead, they say, yes, you do have control over the voices that you hear in your head. And let's identify and employ actions that could lessen those voices. So when you think, I'm hearing some voices in my head, right, I'm going to control this. I'm going to distract myself. I'm going to listen to music. I'm going to do some cooking. I'm going to go out in the garden. And it's all things to distract those voices. And again, puts the control on the person that has schizophrenia. They are in control of the voices, which links to them feeling empowered. The patient can also rate the severity of the voices. So was it a 5 out of 10, how severe they were? And then once you listen to music, was it a 1 out of 10? Which again, just makes them realise that they can control the voices they hear. And then we've got behavioural skills training. So this is a range of effective behavioural strategies. So relaxation, activity scheduling, distraction, and problem solving. So relaxation is very similar to that homework thing I showed you before, created by Laura Smith. Activity scheduling is just making sure that you have something to look forward to every day, and whether that's going to the gym or going out with your friends, or going out for dinner. Just something to look forward to. Distraction techniques, so things like gardening, hobbies, clubs, listening to music, but then also problem solving. And in order to problem solve, the client has to work systematically through a series of steps. So they identify the problem that they've got, they generate the potential solutions, and they evaluate those alternatives. They decide, right, this is the solution. This is the best thing for me to help me get over how I'm currently feeling. They try it, and then they evaluate the outcome. And that is all done with the therapist helping and supporting them. And then lastly, we have relapse prevention. So relapse meaning that you get better and then things get worse for you in terms of your schizophrenia. So the therapist and the client identify some early warning indicators. What is it? What allows your brain to think, maybe this is going to go badly for me? And it includes the client identifying their thoughts, behaviours and feelings that they experience before they come unwell. It's giving them insight into their schizophrenia. And they're also asked to assess how well they get on with other people. And after that, they develop plans. What could be employed when indicators are observed? What would the client do? And what would they say to their family and friends? Their family and friends knew, so that they could help as well. And then they plan lots of different support options. So what can we put in place? If it is those distraction techniques, it's making sure the family are able to identify, oh, I'm not sure they're having a great day. Right, let's do something to distract them. It's things that their family can do, but it's allowing them to know what they can do for themselves as well. Okay, so there is your whistle-stop tour of CBT. In terms of prioritising what goes into an exam question, because I know that there is a lot to this, you need to explain what CBT is. You need to tell the examiner that you get it and that you know what it means. You can put in that it's made up of homework activities as well. The main thing is Laura Smith and these areas of her research. So talking through the different types: engagement strategies, psychoeducation, cognitive strategies, behavioural skills training, and relapse prevention. So saying that there are 5 different elements of her theory, listing what they are, and then going into detail about each one is absolutely how I would tackle this question. I hope that was helpful, that session. And next session, I'm going to go over some exam technique and some revision tips that covers the whole of the schizophrenia module, but also the Unit 3 behavioural module as well. So thank you very much for joining, and I will see you all next week. Diolch.